Welcome to the deep dive. Today, we're tackling a really important topic in vascular surgery. It's about using T-VAR, that's Thoracic Endovascular Aortic Repair, for Type B aortic dissections. Fixing that tear of the chest aorta minimally invasively.
That's right. And we're drawing our insights from, well, a really significant piece of real-world research today. It's a study looking at outcomes from the Gore Global Registry for Endovascular Aortic Treatment, specifically focusing on patients getting T-VAR for these Type B dissections. It's actually one of the 50 landmark papers in the field.
Yeah, and what's great about this one is the scale. I mean, this isn't some small trial. We're talking about a huge registry tracking, what, over 5,000 patients?
Over 5,000 total, yes. Across 113 centers, 14 countries. It's pretty extensive.
And for this specific deep dive, we're zooming in on the 264 patients within that group who had T-VAR specifically for a Type B dissection. So it gives us a really powerful look at how this actually works out in, day-to-day practice.
Exactly. And just for context, the way these were initially handled was mostly medical management, right? Controlling blood pressure, watching, and waiting, essentially.
Right. Until T-VAR came along.
Exactly. It wasn't really until the late 90s, Dakin Nienberg, published in 99, that T-VAR was introduced, using a stent graft to fix the tear directly. And, well, its use, especially for the acute, uncomplicated cases and the chronic ones, that was pretty controversial at first.
Yeah, I remember that. So our mission today really is to pull out the key findings from this big registry, the Great Registry, they call it. We want to understand how T-VAR is actually performing for patients with these Type B dissections, both the recent acute ones and the ones that have been around longer, the chronic cases.
And hopefully shed light on some of the nuances and maybe remaining questions.
Okay, so let's start with the registry itself. Great.
Yeah.
What exactly is it?
So GREAT stands for Global Registry for Endovascular Aortic Treatment. It's a prospective study, meaning they planned it in advance and collected data moving forward. Multi-center, obviously.
Right.
And the whole point is to gather real-world data on how these aortic endografts perform. The stent grafts used to repair the aorta from the inside.
And this specific data set we're looking at?
This chunk of data is from 2010 to 2016.
Okay. And you mentioned Gore earlier, so all the devices in this part of the study were from W.L. Gore.
That's correct. For this analysis focusing on Type B dissection, yes, it was the GORE-TAG device.
Got it. And the patient breakdown, you said 264 total for TBAD. How did that split between acute and chronic?
It was 170 acute cases and 94 chronic cases.
And demographics. Anything stand out?
Pretty typical for aortic dissection, actually. Mostly male, about 80%, and the average age was around 62.
Okay. So we've got the setup. Let's dive into the findings. What did this real-world data show about how these patients did? What about survival and these aortic events they tracked?
Well, the early results, looking at the first 30 days, were actually quite positive.
Oh, good.
Yeah, the 30-day mortality directly related to the aorta, or the procedure, what they call aortic mortality, was very low, only 1.5%.
Wow, that is low.
And all-cause mortality, so deaths from any reason within that first month, was also low at 2.3%. Interestingly, at that early point, they didn't see a big difference between the acute and chronic groups.
Okay, that's encouraging for the short term.
Yeah.
But, the real test often comes later, right?
Yeah.
What about the longer follow-up?
Exactly. So they followed these patients for an average of 26 months, so a bit over 2 years.
Right.
Over that time, the total aortic mortality stayed low, 2.7%. But the all-cause mortality climbed to 12.5%.
Okay.
And here's where a really key difference popped up. The all-cause mortality was significantly higher for the patients who had chronic Type B dissections compared to the acute ones. We're talking 19.2% versus 8.8%.
Wow, that's more than double. 19.2% versus 8.8%.
Yeah, it's a substantial difference. It really suggests that, while T-VAR might stabilize things initially, the long-term picture for chronic dissections might be more complicated. Perhaps those patients have underlying issues, or the aorta itself is just, well, less healthy long-term.
That makes sense. It highlights that maybe the chronic condition itself carries more long-term risk, even after the repair. Did they find any subgroups that did particularly well, maybe within the acute cases?
Yes, they did. They specifically found that patients with acute, uncomplicated dissections, so recent tears without immediate life-threatening complications, those patients had significantly better overall survival compared to all the other groups combined.
Other groups meaning acute complicated, chronic uncomplicated, and chronic complicated.
Exactly. For the acute uncomplicated group, the 2-year survival was about 93%. For all the others lumped together, it was closer to 83%.
93% versus 83%. That's a pretty strong signal that intervening early in those uncomplicated acute cases might be really beneficial.
It definitely suggests that, yes.
Okay, you mentioned aortic events earlier. That sounds like it could cover a lot of ground. What exactly did they include in that definition?
Right, it was a pretty comprehensive definition. It wasn't just about survival. An aortic event included, obviously, aortic mortality,
Yeah.
but also things like aneurysm formation or growth where the aorta bulges out,
Okay.
aortic rupture, which is catastrophic, spinal cord ischemia, lack of blood flow to the spinal cord, a known risk with these procedures, stroke, any complications with the branch vessels coming off the aorta.
Hmm.
Also, issues related to extra procedures sometimes needed, like debranching, retrograde dissection, which is really serious, where the tear goes backwards towards the heart.
Right, into Type A territory.
Exactly. New dissections further down the aorta. Endoleaks, where blood still gets into the tear sac around the graft. Persistent flow in the false lumen, the torn channel, and even graft infection. So, yeah, a wide net.
Definitely covers a lot. Okay, so shifting gears a bit, what about anatomical factors? Did the study find anything interesting there, like the shape or size of the aorta?
One thing they noted was that patients with chronic dissections needed significantly longer graft coverage than the acute patients.
Longer grafts, why might that be?
Well, the study didn't definitively say why, but you could speculate. Maybe the chronic dissection involves a longer segment of the aorta, or perhaps the tissue is just different and needs more reinforcement.
That makes intuitive sense. More time, potentially more damage or extension.
Mm-hmm.
What else on anatomy? You mentioned the landing zone before.
Yes, the proximal landing zone. That's the bit of healthy aorta right before the tear starts, where you anchor the top of the stent graft. This was a really crucial finding.
Okay.
They found a significant link between having a large proximal landing zone diameter specifically, if it was over 40 millimeters wide, and a much higher risk of developing that retrograde type A dissection we just mentioned.
Oh, much higher.
Dramatically higher. About an 18% risk in those with the landing zone over 40 millimeters, compared to only 2% in those with landing zones under 40 millimeter.
18% versus 2%. That's huge.
Yeah.
That really flags it as something surgeons need to watch closely during planning.
Absolutely. It highlights how careful pre-op imaging and sizing are. Getting that anchor point right in healthy tissue of the right size is paramount.
Okay. Now, there was one finding you flagged earlier as counterintuitive, the one about the left subclavian artery, the LSA. What was going on there?
Ah, yes, this was fascinating. So the LSA is that big artery branching off the aorta that supplies the left arm. The initial analysis of the GREAT data showed something unexpected.
Which was?
Patients whose LSA had to be covered by the stent graft during the T-VAR procedure actually had a twofold higher rate of aortic events compared to patients where the LSA wasn't covered.
Wait, covering it led to more problems? That doesn't sound right. You often have to cover branches like that to get a good seal for the main graft, don't you?
Exactly. That's why it was counterintuitive. But it didn't stop there.
Oh.
They also looked at patients where the LSA was covered, and they had a separate procedure to reestablish blood flow to the left arm, a revascularization.
Okay, like a bypass or something.
Right. Those patients also had a higher rate of aortic events, about 1.5 times higher, compared to patients who just had the LSA covered without any revascularization attempt.
So covering it seemed bad, and covering it then fixing the flow seemed also bad, or at least linked to more aortic events. That's really puzzling.
It was. And it definitely made the authors and the commentators on the paper, Gregory McGee and Fred Weaver, pause and think. Their commentary talks about this and about how our whole approach to treating Type B dissections has evolved since 1999.
Right.
They point out that the best way to handle T-VAR, especially for those acute, uncomplicated cases and the chronic ones, is still, actively debated.
And they mentioned some of the other big studies, right? Like Instead. How did
Yeah.
that fit in?
Yeah, the INSTEAD trial was key. It was a randomized trial comparing T-VAR against just medical management for stable Type B dissections. Initially, at 2 years, it didn't actually show a survival benefit for T-VAR. Yeah, and this is important, when they followed the same patients out longer, to 5 years, they did find that T-VAR led to better aortic remodeling, the aorta healing, and reshaping better and significantly improved long-term survival.
Ah, so the benefit took longer to become apparent.
Precisely. That longer-term data really helps shift opinions and build support for using T-VAR more often, particularly in stable or uncomplicated scenarios.
And there was another registry mentioned, IAD.
Yes, the International Registry of Acute Aortic Dissection, IAR. Data from IARD has also generally supported the idea that T-VAR offers survival advantages in certain Type B dissection situations, so the evidence has been building.
But the authors of this great study acknowledged limitations in their own initial analysis.
They did. They noted it was retrospective, looking back at collected data, and its main focus was just counting those post-op aortic events. Critically, it didn't have all the detailed imaging data needed to really analyze why things were happening or how the aorta was remodeling.
Which left that weird LSA finding kind of hanging there.
Exactly, which is why they dug deeper.
What did they do?
Well, they went back and did what they called a more granular analysis, looking specifically at the detailed data from their own hospital's aortic database.
Okay, a closer look at their own patients.
Right, and that analysis revealed something important. Landing the graft in a non-dissected part of the aorta, which often requires covering the LSA to get a good seal just beyond the tear. That was actually associated with less risk of retrograde Type A dissection.
So covering the LSA might be necessary sometimes to achieve a safer proximal landing, even if the initial registry data flagged it as a potential issue overall.
That seems to be the implication. It suggests a trade-off. Cover the LSA to get a solid landing in healthy aorta, potentially reducing the risk of the tear extending backward.
Okay, that starts to make more sense. But what about the higher rate of other aortic events linked to LSA coverage or revascularization in the first analysis?
They looked into that too, using a different, much larger database, the Society for Vascular Surgeons Vascular Quality Initiative, or VQI.
And what did the VQI data show?
Analyzing the VQI data, they found that when patients did have their LSA covered during T-VAR, performing a revascularization procedure to restore arm blood flow was linked to a significantly lower rate of spinal cord ischemia.
Lower rate. Okay, so now revascularization looks potentially protective against a specific serious complication, even if the initial great data hinted at more overall aortic events.
Exactly. It paints a much more nuanced picture. The initial signal from the Great Registry about LSA involvement wasn't wrong, but it was incomplete. It seems covering the LSA might be needed for a good seal, and if you cover it, revascularizing it might actually mitigate the risk of spinal cord problems.
Wow. It really shows how you need to keep digging sometimes and how looking at different data sets can refine understanding.
Absolutely. And the authors noted that based on these further analyses, their own clinical practice has shifted. Now, they routinely revascularize the LSA if they plan to cover it. It's a great example of how clinical practice evolves with evidence.
It really is. Science in action, like you said. And they finished with a call for others to share data too, right?
Yes, they made a strong point about wanting other endograft manufacturers to publish their post-market registry data as well.
Why is that important?
Because real-world results aren't always the same as what you see in tightly controlled trials, and different device designs might have slightly different outcomes. Getting all that data out there helps everyone learn and could ultimately lead to better grafts and better patient care.
Makes total sense. Okay, so let's try to wrap this up. If you had to boil down the key takeaways from this deep dive into the great registry data on T-VAR for Type B dissection, what would they be for our listener?
I'd say first, T-VAR with the GORE-TAG device seems like a solid option for Type B dissection. The immediate aorta-related risks appear quite low.
Okay, low short-term risk.
Second, and this is crucial, there's a big difference in long-term outcomes. Patients with chronic dissections fare significantly worse in terms of overall survival compared to those with acute uncomplicated ones. Chronicity matters a lot.
Right, that 19% versus no percent mortality difference was stark.
Definitely. Third, that anatomical point about the proximal landing zone diameter over 40 millimeters being linked to a much higher risk of retrograde Type A dissection. That's a critical piece of information for procedural planning.
Absolutely vital for the surgeons doing the procedure.
And finally, the whole left subclavian artery story. It's complex. While covering it might sometimes be necessary for a good seal and initial data raise flags, further work suggests revascularizing it when covered might actually be beneficial in preventing spinal cord issues. It really highlights how interpreting real-world data takes careful, ongoing work.
It really does. It shows we're still learning and refining. So thinking about all this, the differences between acute and chronic, the anatomy, the LSA nuances, it leaves us with a big question, doesn't it? Given how much we're learning, what are the most critical factors we should be using right now to decide the best treatment path for each individual patient with a Type B aortic dissection? It really underscores the need for that personalized approach driven by the latest data.
Absolutely. It's about tailoring the treatment to the individual's specific situation.
Thanks for joining us on this deep dive.